So thank you for coming on. So the last two ones we've been doing respiratory conditions. So I want to move to something a little different. And this is really especially for you guys coming in new. I want to talk about malnutrition, mostly so that you guys have a sense of what is happening on the malnutrition program. Because you'll notice ELWA, we are running quite a large malnutrition program at the moment. I know it's not very full, but most of the time we have 15 IPF beds. They're usually very full. And then we have the busy OTP as well. And this is where you will see a lot of pathology, and you'll learn a lot about malnutrition and child health. So I'm going to try to do the screen share. Let me try to make this work. Okay, right. Can you all see some PowerPoints with malnutrition written on it?
Yes, sir.
Oh, good. Excellent. Excellent. Yes, it's working. Good. So feel free to ask questions as we're going, and to if you have questions, just interrupt. That's very good. Always happy for that, or put a message in there. That's always a good thing to do. Dr. Sanu, you're also joining. Excellent. Welcome. So
thank you. Is Dr. King?
Oh, I see, Dr. King. Yeah, great. Sorry, it says Ibrahim Sanu. That's fine. Are you in Harper?
Yes, I'm in Harper.
Oh, excellent. Good, good. Oh, thank you for the work in Harper. And so malnutrition, really main thing to understand to start with. The more we can understand it, the more we'll be able to give good care to the children as they come through the hospital. It's actually very common in Liberia. We see a lot of it. But the thing to try to understand is a little bit of, it's not just the healthcare side, it's also the social and the family side of it as well, because a lot of these children will face really big barriers to actually getting into the hospital. And what we've got to try to do is deal with some of those barriers so they actually get in. So really, I'm going to start with a bit of a recap. You probably all know this. There are broadly two subtypes of malnutrition. You have the marasmic subtype, which is very, very obvious. It's the one that you will see maybe 80% of malnutrition children have this. The kind of very wasted appearance. You can see all the ribs. You can see that they're very irritable and lethargic. People will say they have an old person face. There's obvious kind of wasting of the arms and buttocks as well. And they'll just be very, very weak and less able to mobilize around. And you can see the little picture there drawn of slightly distended abdomen, but everything else is very, very weak and lethargic. Then you have the second subtype, which is kwashiorkor, and this is actually more difficult to diagnose, because when you see a kwashiorkor child, sometimes if you're meeting them for the first time, you might think that they're not malnourished, they have lots of, they have lots of weight covering them, but actually the kwashiorkor children are actually more unwell even usually than marasmus. Because what has happened is their protein levels are so low that they cannot even hold fluid in their bloodstream through the osmotic pressure. So these types of children get very, very unwell quite quickly, and they're quite delicate to manage. And when you meet them, you'll see the arms and legs are very edematous. You'll see both feet will be swollen. The hair is very pale. The skin looks like it's peeling. Very lethargic and sleepy. So all these kind of things would make you think the child has a kwashiorkor subtype. So just to give you a couple of pictures, you've probably all seen children in this condition. If you've worked on the ITF, you will see on the left, you can literally see all the spinous processes of the vertebrae. You can see the ribs. You can also see some skin changes there on the buttocks, and the child is clearly very, very lethargic, needing to be supported and held up there by someone in PPE. So a very, very weak and lethargic looking child. And then on the other side, you can see there's a child who actually, when you first meet them, you'll see they look quite fat. But if you look at the orbital area around the eyes, there's bilateral periorbital swelling. And there's clearly some swelling in both of the maxillary areas there. And then if you actually look at the abdomen, that's just pure distension. That's not a normal abdomen. That is just purely sort of water and fluid. And if you were to press on the hands and feet there, you would notice quite obvious edema. So just to be aware, especially kwashiorkor types, often the family will not realize that the child is unwell. So they go around in a circle because they think, the child is actually being fed quite well, so they don't bring them to hospital, so they go round and round. And you will see sometimes even PAs and nurses will not recognize this subtype. So it's very, very important, especially if you're working in under 5 clinic, or even in Harper. I know they have these patients, that we're the ones who will need to probably recognize these. And the easy way to do it is to look for pitting edema. Now, pitting edema in a child is always pathological. And you will usually find it as related to nutrition, but you will also see it in children with cardiac problems. So, for example, if a child has a VSD and they're decompensating, or if a child has liver failure and they're decompensating, then you will see bilateral pitting edema. And it's a really easy test. You just pop your thumb on the feet and you'll know straight away, okay, this is edema. This is something I need to take seriously. So these children, they're very strange. When you first admit them onto the IPF, what you will find is that if they're getting better, they will very rapidly lose weight. So we had one child back in June who actually weighed 7.5 kg on arrival. Within about 5 days, the weight had gone down to 6.7, and everybody was panicking because the weight had gone down. But that was fine. They were just losing all their edema. So expect them to lose weight when they first come on bed. Just to explain a little bit of the pathophysiology, essentially marasmus is what happens when the body's energy requirements are greater than the amount of energy the body can make. So you get, the body will break down through all the glycogen, then it will break down all the adipose tissue, and then when that's not remaining, what happens is the muscle tissue starts to get broken down as well. So essentially you've got gluconeogenesis coming from the amino acids that are actually in the muscles, and that's why the buttocks and everything get very, very wasted. So if someone has one of these types of malnutrition, they've probably been unwell for quite some time, because the body will have already used up all the glycogen and all the adipose tissue stored before they get into the muscle. Kwashiorkor is a little different. Essentially, what happens is they're using up so many amino acids that they're actually starting to break down some of the proteins that are actually in the bloodstream. So you end up with essentially fluid seeping into areas where it shouldn't be. And kwashiorkor children sometimes will even get pulmonary edema as well, just to be aware. So those are your two types, but you will encounter mixed types, so kwash maraz. So sometimes you will encounter children where the arms and legs are very wasted, but the feet are very swollen, and maybe they have a hepatomegaly, and you'll encounter a mixture of the two. So just be aware, sometimes you'll meet them both if they're in a severe state. So those are your two subtypes. And once you understand that, really that helps you to know what to do next. Now, again, a little bit of a recap. If you want to diagnose severe acute malnutrition, you need to measure the child. There are really just 3 criteria that we use to get a child onto the program. Now, this is not easy, because sometimes in real life, you're going to have parents who will come to you and will say, oh, but my child's body is dry, and they'll give you all this story. But actually, they have to meet those criteria before they can actually come onto the program. The reason for that is if you put people who are not meeting those criteria on the program, they don't actually get better. So it's very strict. So the first criteria is the mid-upper arm circumference. This is the easy one to do. This is the one that you do when you're sitting in the ER and you maybe you have a child come in an emergency and you see they're looking malnourished and you want to know maybe what kind of fluid to give. That's the easiest, quickest way if you use your mid-upper arm circumference tape. So this is a sort of thing you can only really practice doing. It's a very good thing to be able to do. It actually comes up in the OSCEs as well, just so you're aware. And all you're doing is you're using the tape. You're putting, basically wrapping it around the middle of the upper arm. You put the one end inside where the little notch is there. And in the window with the arrows, if you're seeing red, that means the child is malnourished at a severe level. If it's yellow, that would be moderate malnutrition. If it's green, there's no malnutrition. So that's the easiest way. And then you look, the other one would be the weight for height, less than -3. And you meet a lot of children in this category. Something like maybe 1/3 of the children who come to under 5 clinic will meet criteria with a weight for height less than -3. And the other thing is bilateral edema. So just be aware, MUAC does not work for children under 6 months. So under 6-month babies are a special category that we're going to talk about later. And also over 12 years, you would need to use weight for height as well. So just be aware that there are some exceptions. Now, a child with pitting edema of both feet, you don't need to do any more measuring. Immediately, you can tell that child has malnutrition or some other problem. So that child will be coming on bed straight away. So just to be aware, those are your 3 criteria to diagnose. And just to give you a sense, you'll meet these charts everywhere on the ward. You'll find most of the nurses in the IPF will understand how to use these charts. They have a weight, they have a height. The height is down the side. The picture is not too clear, but you can see the height on the left, and you will see the weight that they are expected to be in the median. So their average weight is the nice dark green. Now, if they are less than -3 standard deviation, so if they are in the light, the kind of the light pink or the dark red, then that puts them in the severe acute malnutrition category. So really, that's the only part that you need to know about. And what you need to do, if you see them in that category, is you need to admit them onto the program. Now, we're going to talk in a second about what it means to bring somebody onto the program and what it means to admit somebody on bed, because there are basically 2 different understandings of that. So if you are in the severe category, then you need to be admitted onto the program. Now, that's either you're on the outpatient feeding or the inpatient feeding. Once you've realized someone's malnourished, then you come to a decision tree, which is essentially this. If you can all see this slide, this is a really important slide in understanding the malnutrition program. If you can get this slide, then you will understand what is happening really with all these children and the flow of patients. So a patient who has malnutrition, you look at, you do your tests here. If the child has edema, then immediately they're going for inpatient feeding because they will not get better on the plum peanut alone. They need to be an inpatient. If they don't have edema, then you check for any medical complications. So by that, I mean, does the child have malaria, pneumonia, fever of unknown origin? Could they have typhoid? Is there a possibility there might be a new diagnosis of HIV? Any other thing? If that's going on, then they need to be admitted on bed. Similarly, a child who fails the appetite test, so a child who is not able to tolerate the plum peanut, so you give plum peanut to the child and they just don't take it in, or they vomit it, or they just can't manage it, they would go into what's called the IPF, so the inpatient feeding. But if you have a child who, say their weight for height score is maybe less than -3, their MUAC is maybe 10.5, but you see the child is, you know, a good appetite, they're eating the plum peanut, they're tolerating medicine, then you manage them in the OTP, so in the outpatient feeding program. So it's a common misperception. A lot of people think that if you diagnose a child with any kind of severe malnutrition, then they need to go on bed. It's not always the case. If they're able to eat the plum peanuts and if they are well and stable, then they're managed in the OTP, in the outpatient feeding. Sometimes there can be a lot of confusion if someone's not worked in the nutrition program before. Sometimes they get confused. They see, oh, all these children with red, right? They all need to come on bed. But if you do that, you'll find the whole nutrition program will just be full of children. And also the mothers will not be happy because they have other children at home. So that's why the IPF is limited to the children who are the most unwell and who are not tolerating the plum peanut. So just good to be aware of that. So just wanted to give you a couple of pictures. You can see obviously on the left there, this is one of the children at ELWA a few weeks ago. RJ sent me this picture. This is a little one. Clearly you can see very malnourished. You can see all the ribs. You can see the arms and legs are very, very wasted. And the other thing, if you look at the child's facial expression, very lethargic, not really interacting. You can even see male pattern balding. All those things would tell you. But to give you a sense of how difficult this is, so on the right, you can see this picture. This is one of the nutrition outreaches that they go on. And you can see Dua, who's basically the acting supervisor at the moment. In the background, you can see all these children and all the mothers. And there's like 100 plus will come on these outreaches. So it's very hard sometimes to identify them all. So what's very important when we do the outreaches is we'll go into a community where we'll call all the leaders, all the mums will come with all their children, and they'll meet all these different children who will all need to be weighed and measured. And this is a really important part of the program. So I'd really encourage you guys, if you are rotating in peds, to go on one of the nutrition outreaches, because you will get to meet all of these families, and you will sort of be in that community. And what we will do is we'll identify the cases there, and then we'll bring, usually we can bring them back to ELWA if they're very severe, or we give them information on coming the next day. Sometimes they don't want to come on that day, so we try to bring them in. But you'll see a lot of patients in there, so it can be quite challenging to find the most malnourished ones in the middle, but we always do that. So that's basically, I just want everyone to get that in your mind. Are there any questions about that decision tree for malnutrition? Any questions on that? Making good sense. Good. So that's just a very important thing to have in your mind. So what we do really is basically anyone who, we have this broad categorization of complicated severe malnutrition versus uncomplicated. So complicated is all the children who are coming into the IPF. And this is, as we said, any child with the edema, anyone who's not passing the appetite test, and also any child who has a medical problem. And this is very important. Then we have uncomplicated, which is in the OTP. Now, really, when you do your peds rotation, I like it for residents to spend at least 1 day a week in under 5 clinics, so that you get to see some of the primary care aspects. You get to maybe spend some time mentoring the PAs and seeing just a large number of children. This is where you will meet the uncomplicated cases. So it'll be a child with no ongoing medical complications, but the child is eating well. And then you will see that they're managed as outpatients. So on their first admission, start them on usually just amoxicillin, and you do an HIV and TB screen, and you start them on a nutritious feed. And there's a few other things that have to take place. It's quite a strict sort of program they go through. So on a weekly basis, they're followed up. And this has been one of the challenges, is sometimes they'll come, they'll be diagnosed, and then they'll say, oh, no, I can't come because blah, 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 I've got family commitments. So we really have to do a work of education with these mothers, and just explain to them how important it is, because sometimes when they're first diagnosed, they'll come and then they'll go for like 4 weeks and then they come again and the child is even worse. So we have to really push them to be coming more regularly. Also, first presentation, they get given an anti-malarial as well, just Coartem if they can take it. And then at week 4, they're dewormed and they get given vitamin A. Very important not to miss those stages. And like I said, health education all the way through. So just to be aware, children with uncomplicated malnutrition, they'll be coming every week, and they can very easily change between complicated and uncomplicated. So what can happen is if the child is not eating very well, or they start refusing to take the, basically they start refusing the plumpy nut, or their weight is going down, then they will actually start to become more complicated. So they will start to need inpatient feeding. And so that's why you'll sometimes meet a child who has been coming for maybe 5 or 6 weeks, they're not seeing improvement, the weight is still going down. If you see that, then they need to come on bed. So very important to be following them up. And just to be aware, it's not just a one-time antibiotic amoxicillin and forget. If the child comes back to you and there's the mum saying, oh, the child is still coughing, the child is still breathing a little fast, then you want to be thinking about other things. Is there another pneumonia? Do we need to think about TB? So each time they come, we're doing an active screening of the children. So complicated, like I said, anyone who fails the appetite test, edema, medical complications, they need to come into the IPF straight away. And just to stress, this treatment is free. It should be sort of nationally with the Ministry of Health and the Nutrition Division. There's a big drive to roll out free malnutrition treatment in the country. And so this is a really important part of that. And it's really important just to stress to you guys, if you see it, children are being sent to buy medicine and all this kind of blah, blah, blah. It's really important that you say something about it, because it should not be happening. It's really important that we hang on to that free treatment, because these families are coming with malnutrition. They are not wealthy. Just to show you a little picture, this is some of the so Joanna,
okay, I will think about
it. For these people, and very good people. And just to stress to you, the IPF nurses have all been through the malnutrition training, which is run by basically the Ministry of Health and also Samaritan's Purse. So a lot of them are actually able to do some prescribing independently. Now, they will still need your help, but they will usually be able to start the initial treatment in the IPF, and they will know how to do appetite tests and all these things themselves. So that's really, really important just to stress. So they are not the same as other nurses. They are specialist nurses. So when you encounter them, they have a specialist set of training, and they are slightly, as a result, they're paid a little bit more, but they do have that extra specialism. So my advice to you, if you are setting up one of these programs and say you graduate, find yourself in a hospital, you want to set up a nutrition program, the first thing you need to do is to develop your nurses and your PAs so that they are trained at least a little bit in the IMAM principles, because if they are, then they will do a lot of the work for you. Because if you imagine you're the only one doctor in some hospital that is far in the bush, you need your team around you. So first thing to do is to engage nutrition division and try to get some of these people trained. And they will do a lot of the initial management for you. So I've learned to trust the nutrition nurses, quite a lot, and they will do very well for you. So just to say, I love my ABC. It's very important in pediatrics to have a system when you're encountering a sick child. So if I'm seeing somebody who's sick and I see someone seeing them and I see a system, I know you all have your SOAP system for note writing, but also ABC is very important in children, because that tells you where you are. So obvious issue is, any the airway blockage. But then first things first, start with the breathing. Is there respiratory distress? Is there pneumonia, TB, anything like that? Now, again, oxygen is completely free at ELWA for malnutrition children. We have dedicated oxygen concentrators for children with malnutrition, so we do not have any kind of oxygen shortage going on. So, if you encounter these children with breathing difficulties, please use the oxygen available. Circulation, next thing, remember to check for shock. We all know 3 signs of shock. Can anyone tell me in a child, what are the 3 signs of shock? My favorite ETAG question.
Rapid capillary refill.
Very good.
Cool and clammy skin.
Wonderful. Yeah.
Yeah.
Fast and weak pulse. Yeah. So those are your 3. So you had it. Cold periphery, so cold hands and feet, CRT greater than 3 seconds, and fast and weak pulse. So very important in any malnourished child, check for shock, document it, check for pallor, is the child anemic, and then look at dehydration. Now we're going to look on dehydration a bit later, but it's very important to ask about diarrhea, because a child who has very severe malnutrition, they will look dehydrated even when they're not. So it's very important to ask about that. And then other things, children with malnutrition, very much at risk of hypoglycemia. Essentially, it's substrate deficiency. They don't have enough glycogen to metabolize, so they have very, very high risk of hypoglycemia. And so that can lead to things like coma, convulsions. Over time, they can develop high temperatures or become hypothermic. So really important to keep all of those things in your mind. Then other obvious things when you're examining sort of the ABCD, and this would be the E, the exposure, look at wasting of muscles, any edema, look at the eye changes, and then look in the mouth for ulcers, and then anything obvious in the skin. Is the skin peeling? Are there any infections, hair color, texture changes, anything like that? So just to say, you've got a collection of conditions that you need to treat quite quickly before you really get into the catch-up feeding. So the key thing with any malnutrition program to be a success is to realize it is not just about feeding starving children. It is about the whole medical thing and understanding how the child came to be malnourished and then trying to treat them according to that. Are you still there? Yep. So it's very important to try to have that in your mind. So we're just going to go through that. Now you'll meet this picture everywhere on PEDS ward in the IPF. You'll meet this. Remember your ABCD, and then your antibiotics. Ministry of Health and International and WHO recommends the Ampingent as first line, but that is flexible. And we're going to talk about antibiotics a bit more, because the nurses will start the Ampingent. Really, as doctors, it's our job to look at the whole situation and say, well, what is really going on with this child? Is there something else happening here that we need to be considering? I'm sorry that some of these units are a bit British. The RBS less than 3, that's really less than sort of 56 there, really. Just remember hypoglycemia. If you find yourself in a rural setting and you have no glucose machine, then you should treat the child with dextrose, either orally or IV, immediately if you see that. Sometimes even in the IPF, if they have no glucose machine, they will just jump straight in and start treating the child with either dextrose or sugar when they first meet them. So it's really important to do that, because these children are at very, very high risk. Remember hypothermia as well, and then you move into your feeding. So that's a summary. We're going to talk about that in more detail. But I want to just talk about shock. So it's very, very easy with children, when you see a sick child, just to say, okay, let's open line hang fluid. Now, it's more complicated than that. Whenever I see fluid on a child, I always like to ask the question, what are we treating? Are we treating shock? Are we treating dehydration? Are we treating hypoglycemia? Are we doing maintenance fluid? Because just putting up fluid without thinking is potentially very dangerous. So that's why I like us to think about what kind of fluid are we doing. And fluid is more complicated in children than people realize. So you'll meet a lot of nurses and PAs will just be hanging fluid. So really, as doctors, we have to come in with a little bit of understanding and try to explain what kind of fluid we're doing, try to look at why, try to prescribe fluid in an organized way. So when you meet a child in shock, first question you ask yourself, are they malnourished? If they're not malnourished, there's a whole treatment plan of multiple boluses that we'll talk on. But if they are malnourished and in shock, your next question is, what is the hemoglobin? Now, in a malnourished child, the hemoglobin, if it's greater than 6, you don't need to rush to transfuse. Because if you transfuse too much, you'll put them in heart failure. But if it is less than 6, then you transfuse 10 mils per kg of blood. Now, any child with, basically, if the hemoglobin is greater than 6, they're in shock, then you're giving one bolus only of 10 mils per kg of fluid, and you use either DRL or DNS. Can anyone tell me why do we use DNS for shock in malnourished children? Why not just use straight NS? Very good. Yeah, risk of hypoglycemia is very high. So if you just put fluid with no glucose in, you'll find the sugar will go very low. So that's why we have that different plan. So shock with malnutrition, you're using DNS or DRL. And you'll find one of the things I do when I'm making my round is I'm very particular about fluids, because I think it's very important for us to get fluid management right. So just to understand that is treatment of shock. Now, if the shock is still persisting, you can do it maybe one time again, but not really more than 2 or 3 times. And it's very slow. It's over 1 hour. And any more treatment, we would need to be doing something called Resomal, which we're going to talk on in a second. So talk about hypothermia, hypoglycemia. These are like the evil, hypothermia and hypoglycemia, they're the evil step parents. They're very bad. They always come together and they cause a big problem. So be aware as well, a child with hypothermia, that may be a sign of sepsis as well, which is why we treat a lot of these children when they first come on bed. They usually get blindly given antibiotics because often they will not have very obvious clinical signs because the body is too weak to fight infection. So it's a little bit like when you first meet a child or a patient who's spot reactive. Sometimes you treat them with an antibiotic like Septrin or something, even straight away, because often you will not know exactly where the source is. It's very similar in the IPF. So just be aware, you will find the IPF is deliberately, it is kept more warm. You know, I deliberately do not put AC in the IPF because if you do that, you have all these children who will get cold. So it's very important to keep these children warm. Similarly, hypoglycemia, if they can feed, when they first come on bed, we'll try to give them some oral sugar. I know the nurses will probably just do that for you, but it's good to check. And then very quickly, you want to start on the feeding. So we're going to talk about the feeding process in depth. Just to say, the other situation where you give IV fluid to a malnourished child is if you have hypoglycemia and they cannot tolerate anything orally. So I just want to give you this slide actually next. These are the only 3 situations where you are giving IV fluid to a child in IPF. If they're in shock, so that's your DNS or DRL. For treating hypos, so 5 mils per kg D10, or as maintenance fluid in one of those maybe surgical cases, or a child is in a coma. Those are the only three situations. So if you meet a child and maybe they're just vomiting, or they have diarrhea, but they are able to drink, they're able to feed, then you don't hang IV fluid. It's very, very important in the IPF, because if you put too much fluid, they can go into heart failure, and then it's very, very hard to bring a child back. And just to go over again, hypothermia, remember it's a sign of sepsis as well. So you treat for hypoglycemia, you've got your antibiotics going, and you try to get the child warm. So make sure they're wearing like a hat or some gloves, blanket, whatever they can do. Don't put them by the window, or they'll become cold. And if they're a small baby, get the skin-to-skin contact going. We'll cover that in a few minutes. So dehydration, very different.
Can you please come in for 1 minute, please?
Yeah, please.
Okay, I have just a small comment about the child in shock for who won't give some oral glucose. I don't know. Should we make sure is not D10 or D50? Because I think, like we say, glucose, some people may take D10 or D50 and give oral, which may not be very nice for the child.
Okay.
But my big concern was also for the two type of malnutrition with quash combined with maraz.
Yeah.
So in the quash, for the first days of treatment, we expect the child to lose weight because the edema is going down, and then the child starts getting weight after a few days of treatment.
Yep.
But in the marasmic case, we expect the child to start gaining weight from the first day of treatment. So for the combined case, what do we expect from the first time of treatment? Do we expect the child to lose weight, or I don't know? It just came to my mind.
Sure. Yeah. So that's a very good question. So let's talk on that one first. So you're right in that the kwashiorkor child will lose weight first, usually quite dramatically. So the first 2 or 3 days, often even the marasmic child may not gain weight because they are just on the F75. So they may not gain a lot of weight. It may be very slow, and then when they reach day 3 or 4, they've moved on to F100. That's when you see the weight gain. Now, if you have a mixed picture, almost certainly they will lose weight, because usually they have the edema, which is, you'll see it on the feet, but usually there's edema around the organs as well. So around the liver or around the spleen, it's also there. So they have that weight to lose as well. So you will see mixed ones, they'll almost certainly lose a bit of weight first as well. But yeah, that's a very good question. Just coming back to the fluids there. So just to say coming back to shock, you're doing your DNS or your DRL over 1 hour, but I think your question was about hypoglycemia. So hypoglycemia, in a situation where the child is able to drink, you would want to usually give, I mean, you don't have to mix up D10 and give that orally. If you can actually give basically glucose dissolved in water. That's actually much nicer for the child.
Okay.
If you're doing it orally or NG. But be aware, if you have a child where the sugar is low, the child may be in a coma or unresponsive. So in that situation, then you have to go IV. And it should always be D10. Because if you just give D50 IV, you have 2 problems. One, the IV cannula will probably tissue. And second, you'll get a rebound hypo. The sugar will go up and then it'll go right back down again. So that's why D10 is the one that we want to use. So good. Does that make some sense? Good question though. Very good question. So just to say,
thank you so much. You get clear to us. Thank you.
Good. Yeah, please, if you have questions, just please feel free. So dehydration, just to say, very hard to tell if a child with malnutrition has dehydration. And when you meet these 2 conditions together, it's very concerning. because they can go downhill very fast. And they might be very wasted. They have a slow skin pinch, even when they're not dehydrated. So it's very simple. What we do is any child with severe acute malnutrition who has diarrhea, like watery diarrhea, more than 3 or 4 times a day, what we do is we treat them for dehydration. Now, the way this works is very, very different to how we would treat a child who is not malnourished, because remember, these children are at high risk of going into heart failure. So our treatment involves something called Resomal. Does anyone know what does Resomal stand for?
Rehydration solution for malnutrition.
Very good, very simple. Rehydration solution for malnutrition. So it's a very specialized thing that we use. Basically, it's given either orally or via nasogastric tube, and you use 5 mils per kg, basically every 30 minutes, or 10 mils per kg every 1 hour. And you do it really in 2 phases. The first 2 hours is usually 5 mils per kg every 30 minutes for 2 hours. The second phase is maybe 5 to 10 every 1 hour for the next 4 to 10 hours. And it's very, very safe fluid to use. Children do get better on this. And normally you just keep giving it until the child's diarrhea stops. But be aware, Resomal will not feed the child. It is just a fluid that is taken orally or via NG. So when you're maybe you're into the child's been on bed 6 or 7 hours, you come back and review them later, you would want to tell the nurses you can start some F75 now as well, because they will start to need to build up some substrate, basically some nutritional products, so that they can actually start to improve. So they will start on Resomal, then you put in the F75, and then over time they should start to improve quite well. So really simple. That's basically all you're doing. And just be aware, we're going to talk more on this later, but children will get diarrhea a lot on the nutrition program. Sometimes they'll be reacting to the milk. It's very common. Sometimes they'll have diarrheal conditions which have made them malnourished. So just some antibiotic decision making. The nurses will almost always put these children straight on AMP and GENT, and that's okay. But our job in the IPF is to be reviewing these children. So after 48 hours, if they're improving, you can think about moving them to oral antibiotics if they're improving. And that is perfectly okay. If they're not getting better, then it's up to us to start looking for a source of infections. You want to listen to the chest. Is there pneumonia? You want to examine the abdomen, examine the head and neck, thinking about TB, HIV. Generally, my kind of go-to second lines are azithromycin if I think there's a chest cause or if there's something happening with the tonsils. And then ceftriaxone is very good for the abdominal things as well. But at all times, remember your spot test, remember TB. So every child coming into the IPF, and again, the nurses will do this for you, they should always have that standard HIV spot test. They should have a hemoglobin. They should have a malaria test. And sometimes they'll do a white cell count as well, but those are your standard tests as soon as they come in. So within 24 hours, you'll have those tests available to you. And that will tell you where you're going, what to do. Just to say a couple of things. Some people can sometimes get very preoccupied with doing lots of blood tests. Now, things like CBCs and ESRs, they're not really too helpful in this situation, because any child with an infection in the nutrition program was going to have a raised ESR. You don't really need to do it. Similarly, a CBC in a child, the reason you're doing a CBC in a child is not to check for infection, because you can tell that with everything else you're doing. You know, has the child got a fever? Are they unwell? Have they got clinical signs? So a CBC, I only really use that if I am concerned about something like a leukemia or a lymphoma or something like that. So it can be very easy to think, oh, let's just do loads and loads of CBCs just because we can, but it doesn't really help the situation here. And most of the time, when you're in a rural setting which is where a lot of these children are, you will not have that facility available. Electrolytes sometimes are helpful, but we don't need to just be checking them in everybody. They're useful in children who are very sick in IPF, but not in everybody. So I don't order a lot of blood tests in the IPF because you don't really need to do that. So it's just to say every blood test you do, you should have a reason for it. And you'll find when I'm rounding, if I'm seeing lots and lots of blood tests, I will always ask questions and challenge. So why are you doing it? It's not that anyone's doing anything wrong. It's just I want to see somebody's thinking as to I want to understand where they are, what they're thinking about, and how they are reasoning. But really, we don't need to do lots of CBCs and ESRs for malnourished children. It's quite traumatic doing that, so we don't need to do it. So initial feeding, we talked a lot about classification and everything, but this is the really important part. And I want to try to get you guys all the WHO Blue Hospital Care of Children pocketbook, because I'm going to try to come with a load of them when I fly out in 2 weeks, because they're very, very helpful for all the residents, all of you guys to have that. That tells you what to do with these sick children. But you'll get all of this information about feeding in there. I wanted to go through it with you. So if you've been in an IPF, you'll know you have F75 and F100. F75 is your starter feed, and it's basically the reason it's called F75 is because it has 75 calories of nutrition per 100 ml. It's very, very simple. And you're starting with small, regular feeds. Now, the nurses a lot of the time will do they will find the amount to feed. They'll do it for you, but it's very good to check. And this is how they do it. There's no complicated calculation that you're doing. You're not doing anything. You're not running around with a calculator. You have a chart like this on the wall, and this comes straight from Ministry of Health, from the Nutrition Division. You have the weight on one side, and then you have the amount of feeds happening each day. So sometimes in more sick children, you do 8 feeds per day. Then if they're more stable, 6, and then very stable, 5. And this will tell you how many mLs per feed. So the nurse aides will mix that up, and they will do supervised feeding for each child. So that is your acute phase, the children when they're first coming on bed. So other things to say, you start with the F75, you're giving a routine medication, you're monitoring the patient. And then as doctors, our main role is to prevent and basically find out if there's any complications that are happening and respond to any children who are not getting better. In the first 3 or 4 days, you will find that these children will take their time, but usually they should start to become more active and alert. If that's not happening, then we need to look for any signs of infection. We need to look for any other conditions. Listen to the heart, listen to the lungs. And the other thing is the stimulation. So if you know the IPF, and I think the one in Harper also has something similar, you will find that there should be lots of painting, lots of toys. The area should be very, very colorful, and very lots of people are moving in and out of the area. So the children are not just lying on bed, not interacting. It's very colorful and active, and a very sort of happy kind of area, really, because they need mental and emotional stimulation as they go. And so F75, very much designed for children who are coming on to the acute phase. So being aware that if a child has been dehydrated for some time, they may have impaired renal function. If they've not been fed, they'll have impaired liver function as well. So that's why we have this specialized milk. Just to be aware, it is not the same as F100. It's lower in sodium, because what we don't want is too much water weight coming on. And it's lower in protein and fat, but it's higher in glucose. So it's designed to prevent the child from going into hypoglycemic episodes. So it cannot just be used interchangeably with F100. It's a very, very different milk. So when you go on the IPF, and hopefully we'll cover some of this in your orientation, you will see there is a big whiteboard thing by the nurses area, and they will have a list of all the beds and how much feed is on each bed. And the nurses will be running around making sure that the feeds are going into each bed, into each patient. Be aware, F75, they are not going to gain weight very fast or even at all. So even a marasmic child, first 2 or 3 days, the weight may just be the same. And it's a recovery process. And as I said, 75 calories per 100 mils. So it's about allowing the body to basically start to bring those recoveries in. So you're stabilizing often the sodium, maybe high or low, you're stabilizing that. You've got the immune function starting to recover. So the child is actually starting to fight off the infections. All these things are just beginning. So usually about 2 or 3 days in, if the child is doing well, you will move them to the transition phase. So when that happens, you change them onto something called F100, which is a much, much thicker feed. So the F100 is basically much more calorie dense. There's a lot more protein and glucose, and also some fatty tissues in there. And this should lead to very fast weight gain. So usually when the child is more stable, maybe they've stopped having fevers, the fast breathing has settled, you put them on F100, and this is where you will see the weight gain will go very, very quickly. It will go from maybe the child will have just been gaining sort of 0.1 of a kg or something. Suddenly they'll be gaining like maybe 0.2 kg, 0.3 kgs every day. And these children start to become a lot more active. They start to play more, and you can see them getting better. And what you do is you gradually transition them to RUTF. And when they are on RUTF, then you also put them on oral antibiotics or an oral antimalarials before you let them go home. Once they are able to take the RUTF, they can go home and they can be fed in the OTP. So this is something very important to understand. You don't need to keep the children on bed all the way until they reach their discharge weight. They can go home when they are eating RUTF, when they are when the medical complication is treated, and when they are more stable. So you will sometimes meet a child, they've been on bed for maybe 1 week. You'll see the weight for height is maybe it was less than -4, now it's less than -2. But the child is eating lots of plumpina, they're doing well. You can send them home and they can be coming and going to the OTP. So that's why sometimes it can be confusing. People say, but they're not reached the discharge weight yet. That's okay. They don't need to get all the way to discharge weight in the IPF. You move them to the OTP. When they get to OTP, then they are able to have the peanut food down there, and that's how they improve. So,
Dr. Mikey, are you there?
Yeah, I'm here. Can you hear me?
Yeah, we can hear you. Thank you so much. That's so interesting. I'm so happy with the last point about the condition which improves. And the child can go home even if the child did not get all the weight we expect on that time. That's so interesting for us. But I want to ask another thing, to switch the chart from the F75 to 100. You put something very important, which is a condition of improving of the child. Does the time too important? Like, I mean, if the child has been on F75, maybe for 5 days, and the child did not improve enough, can the 5 days push you to say, okay, no, I have now to see the child from F75 to 100 because the child has been on the 75 for 5 days? Is that, I don't know what to think about that.
Okay, yeah, so question is about the time. Yeah, so there is not really a strict rule. So if you see the child is still very sick, maybe the child came with malnutrition and also meningitis or something, and they're still very critical, I would keep them on the F75, you know, even longer. I think the longest we had a child on F75 was almost up to like 10 days. So, you know, that is okay.
Thank you so much. Okay.
Yeah, so it's not as if there is like a strict rule where it's like you have to do so and so. So it's very flexible on that. But very good points. And just to say again, with the transition phase, if they're well, if they're happy, you know, sometimes if they're when you see there's been some confusion in the IPF, you'll see all these really happy looking children running around the IPF. You know, they don't need to be on bed. They can go. So it's really good to be thinking about that.
Okay. Yes. I just have a question. You know, for low resource facility, especially in countries where you have facilities and it's not easy to reach, the availability of the F75 and the F100 is a point. So in cases where you have patients with severe acute malnutrition and there's no F75 or F100, what do you do in that situation?
Very good. You can actually make it. So there is a way to make it using, I mean, we were doing this at ELWA for a long time before we found Utriguinea. You can make it. There's a recipe in the WHO pocketbook, which I'm going to bring you guys some of those. And that will be, that basically tells you how to make it with basically sugars and oil and flour. That there's a way to manufacture it. Now, the missing piece is actually the minerals and vitamins that need to be in there. So just to be aware, when you make it, it is not perfect, but you can still do it. And it's not too expensive to manufacture it. So I'll teach you the recipe when I come back.
Okay. Question, please.
Yeah.
Thank you. My name is Dr. Matthews, and my attention is drawn to a situation wherein you have both subtypes of malnutrition in a single child, say marasmic kwashiorkor, so to speak.
Yep.
I would like to know, in such instance, is the management modality the same, or is there a difference? And also, the outcome, is there a difference in the outcome?
Yeah, very good question. So management between the two. So normally, if you have a kwashiorkor child, you are going to keep them on F75 for longer. The reason I say that is that they have a lot more chance of electrolyte imbalances. They have a lot more protein deficiency and various other things. So they'll stay on that for longer. Now, outcome-wise, if they're managed well, they can all do well. They can all survive. But the prognosis is actually slightly poorer if they have either kwashiorkor or a mixed subtype. Just to be aware, the prognosis is poorer, but they can still do well. The same principle of management of F75, F100, IUTF applies, but it's very important in a kwashiorkor child, you keep them on F75 until the edema has resolved. So you can imagine if you have a severe kwashiorkor case coming in, lots of edema, they may be on F75, maybe 6-7 days, something like that, before all that, before the edema resolves. So very good question, but basically kwashiorkor children more likely to be on F75 for a longer period. Okay, good. Okay, just to move on a little bit, nasogastric tubes, you've all seen them. Very important to be aware of when to use them. And usually it's in the acute phase. And this is why the monitoring is very important, because a lot of children will not actually be taking the feeds very well, or they're vomiting it, or something else is going on. Especially children with pneumonia. If you have a severe pneumonia, you want to give the child a feeding through a nasogastric tube. So very, very important just to consider that if you see your child is not improving, or if the nurses or the mum is saying, "Oh, child just throwing out all the time, that's when you need to be considering it. Be aware as well, shouldn't normally exceed 3 days, and really only the acute phase. Good, so common problems. Just to say, diarrhea all the time. Now, it's very tempting when people see diarrhea and they'll say, oh, there's diarrhea, let's put Metro or Nystat or some other something. You don't really need to do that if it's just 48 hours of diarrhea coming into the transition phase. Very common, because if you think a lot of these children, they're very malnourished, their bowels are not used to receiving suddenly, sudden amounts of F100 and various other things. So it's very important in these situations just to take your time and really continue the F100, and the child will normally get better. If the diarrhea persists, you might want to do a stool sample. You might want to perhaps consider a different antibiotic or something. But if it's just less than 48 hours, my advice for that is just leave it alone. You'll get better. Other problem, this is a difficult problem, aspiration pneumonia. This is why we have to really be encouraging the staff to be monitoring the feeding well. So a child who is being overfed is at risk of aspiration pneumonia because they inhale the milk, and that can lead to basically usually pneumonias in the right lower zone. And aspiration pneumonias are very nasty. They often don't improve very easily. They're usually sort of anaerobic things or gram-negative bacilli that cause it. So be aware that it's best to prevent an aspiration pneumonia than to treat one, because usually they need prolonged courses of antibiotics, often IV metronidazole. And just to be aware, have a very low threshold for using oxygen in a child with aspiration pneumonia. If a child has a severe aspiration pneumonia, then the chances are they'll start to breathe very rapidly and start to go downhill fast. So it's very, very important to be using oxygen as needed in those situations. Any question before we talk about the small babies less than 6 months?
No, we think everything is okay for now.
Good, excellent. Okay, so I want to talk about really less than 6 month infants are a special category. And these are the ones that are often missed because obvious reasons. They're often not crying, the mums don't realize they're sick. The mortality rates are very high. They often have sepsis without realizing. They don't get enough milk production. Sometimes the mums just leave them. But just to say, they are different to the greater than 6 month children. We're not trying to get them onto plumping up. We are trying to get the child back onto breastfeeding. Now, in some situations that's not possible, but we are really trying to do that. So objective is to get them onto breastfeeding. And just to give you a picture there, that's Margot, works in under 5 clinic. You can see she's got a child who was, I think this child was 6 weeks old. And you can see obviously very malnourished. The facial contours are very eroded there. And this child actually was on bed for about 4 weeks at the time. So really, really malnourished child who needed to come on bed. And they're often very sick. So your criteria for admission are different for less than 6 months. Any child who is too weak to suck effectively, any child not gaining weight at home. Okay, so say they keep coming to under 5 clinic, you see the weight is not improving. Any child with edema and anyone with less than -3 Z score. So again, this is all free. They should not be paying for this, but just be aware, these are your criteria. Any child who is too weak or feeble to suck. So even if they are, even if they look well nourished, but if they're coming and you try to get them to suck and they just can't do it, they're still coming on bed in the less than 6 month category. But predominantly you will meet them in the less than -3 Z score category. So when you see these children, they're often very sick, and it's really important to get them upstairs on bed quite quickly. They have a different chart. Now, it's very hard to talk you through all the nutrition charts without showing you, but they have a slightly different feeding chart. And this is a feeding chart here. If you've worked in the IPF, you'll see that the nurses will chart the weight. And it's very easy for you. All you're doing is looking at the weight to see if it's going up or down or what is going on there, really. And then you make your observations in the space on the back. Very simple. Just to say as well, the treatment is different. You use something called F100 dilute. So it's not the same as F100. It's not F75. The way they mix it is they use the same F100, but they add slightly more water. And that works because it prevents the children from getting dehydrated. You can also use breast milk. So if the mum is breastfeeding very well, but it's just that the child has deteriorated, I will say to the mum, okay, you put the child on breast. If they can't feed, I want you to be putting breast milk into a small bottle. And when it's going in the bottle, then that's the amount that you're giving to the child. But it's very important that the mothers are measuring the amount of fluid that's being given. They can't just be giving fluid without thinking it has to be measured. And you can even use F75 if the child is edematous, but usually you're using dilute F100. So I'm not going to talk about the preparation because the nurses will do that for you. But just say the amount to give, you can see again, there is a chart here looking by the weight. So it's very, very easy. We're not doing any complicated calculation. You look at the weight, you look at the amount to give. And each day when you check on the chart, you'll see, oh, okay, the weight is hopefully increasing. You can start increasing the amount. But if the child is getting better, then rather than giving them more and more dilute F100, you are moving them onto breast milk instead. Now, I want to show you this technique. You may have seen this already. This was actually invented in Liberia. This is a Liberian kind of thing. And the best thing to do, rather than talk you through it, is just to show you the picture. So you can see this picture here. You can see the child has basically got the breast in the mouth. And you can see this is a nasogastric tube going into the child's mouth. And it's coming from a small bottle, which has some dilute F100 inside. And the child basically puts the tube and the breast in the mouth. And they are taking the milk from the bottle at the same time as being on the breast. And while that is going on, you can see the child is feeding, they're taking breast milk, but they're also taking the dilute F100 as well. The reason we're doing that is that technique will stimulate the breast to start producing milk. So it's very good in those situations where maybe a child is like 3 months old and the mum says, oh, there's no titi water. You know, if the mum tells you that, never believe it. You should always challenge that. Because if they're telling you, oh, no breast milk, no titi water, nothing, you know, they are talking themselves into poverty if they do that. Because what will happen is they'll be running around trying to buy milk. They cannot afford it. So that's why breast milk is the most important thing. So you put the child on the breast, you have the milk coming from there into the mouth using the tube. Very, very important that it works in that way. So is everyone getting that technique? It's something we use quite a lot in the IPF.
Yes.
Yeah, good. So you'll see it being done. And then they progress. So over time, they they should be gaining weight. They are doing it a little bit slowly. Now, if the child is losing weight on F100s, first thing you need to do is, we'll just go straight in. You can start increasing the amount a little bit. But you also need to be looking at that child and saying, well, why is this child losing weight? is there some other problem? Are they septic? Is the mother not giving them any food? What is really going on? If they're gaining weight, then what you do is you actually start to reduce the dilute F100. I normally reduce it down to half. And I will say you're going to have half the milk. I want you to keep using that supplementary sucking technique, keep the child on the breast. And then you see if the child is able to keep the weight using the breast milk and the breast milk is coming through again, then you can take it away completely We say you're just going to be doing breastfeeding. That's really important because when these children go home, they will not really have access to milk. These children are very, very poor. So they don't have easy access to buy milk and things. They have to be relying on breast milk. So weight gain that's not maintained, if it's going down, remember you can just keep increasing the amount until you see improvement. Children who are less than 6 months, they are discharged if they are gaining weight on breast milk alone. So you reduce the F100 gradually, you put them on the breast. If they're gaining weight, then you can look at discharging them. If you've treated any medical problem, and if the mother has already had vitamins and minerals, this is very important. We've not been doing this too well, but it's important to also make sure the mother has a good diet. So usually the nurses will at least do some health education, and then they are successfully treated. So a lot of information there. So I'm going to stop there and do a quick summary, and then we'll have some questions. So just to say, very common, remember your two types, but also the crossover, the crash maraz. And then you have your distinction between complicated and uncomplicated. Complicated malnutrition, they're coming into the IPF, and uncomplicated malnutrition, they're in the OTP. Remember, any child less than 6 months, sorry, I should say less than 6 months there with malnutrition, they come on bed, they have their own program. And remember, keep them warm. It's a whole program. We're looking at the cause. And just to say as well, this program is completely free at ELWA. It should be free in any Ministry of Health operated nutrition program should be completely free. There should not be any charges, because if you start doing things, start charging these children, then word reaches the community, oh, if I go to ELWA, they'll take my money and then they will not get better. Or if I go to the hospital money business. So it's really important, the public health aspect, that we just keep that same message all the time. The program is free. Very good. Any questions?
Not really a question, but a small comment is what I do. I think we used to make sometimes like problem is the last 6 months who come to your clinic or they are admitted to the paid ward malnutrition program. They are really sick, they improve. Maybe they improve on 75F, and then you switch on F100, and then you have to discharge them with the family who are very poor. So those children, they can't go home with plum peanuts. It used to be a challenge how to discharge the children home, how to maintain, how to feed them. That's a challenge. I know no one may respond to it, but it's really a challenge.
Yeah, it is. So these are the less than 6 month children when they're discharged home, isn't it? So they've had their dilute F100. Now, really, they should not go home until they have breast milk. If there's no breast milk, we do have an arrangement which was set up. I don't know if it's still functioning, but we have an arrangement with a group called Christian Aid Ministries, who will give milk as an outpatient basis. Now, they were doing it through this Triple T clinic in Douazon. I want them to start doing it at ELWA as well, because really sending them to Douazon and back is not really functioning. So yeah, they should, if there is no way for breast milk to happen, then you're right that they would need some kind of milk support. So Christian Aid Ministries are doing that. I think when I come back, I'll work on maybe trying to fix that link, because it's very, very helpful. The goal is to get the child on breast. Now, if the mother is just saying, no breast milk, or there's some, or maybe the mother has passed or something has happened, then that situation, you do need milk. Yeah.
Sure.
It's kind of a missing piece. So, oops. Okay, any more good questions?
No questions?
No.
I think we are okay. Everything was
Good.
Clear and so helpful. Thank you so much.
Good. Well, thank you so much for all coming on. That's really great. Let me come out of the
Thank you.
Thank you.
Yeah, thank you. So, just to say thank you for all you're doing. Thank you for the awesome work, in Harper and in ELWA as well. I really appreciate you guys. And I